So that's a great question about imaging in prostate cancer. As a urologist, I certainly do a lot of imaging in early stage disease. So prostate MRI is almost becoming ubiquitous for many patients with an elevated PSA, although again, as an old school urologist, sometimes it's being overutilized. For example, a patient has an obvious abnormal digital rectal exam or particularly high PSA, there's still the setting where you can just do a biopsy quickly to get your diagnosis of cancer without, waiting to get an MRI. But in general, for many of our patients, prostate MRI has really taken off and is widely accepted, to work up an elevated PSA. In advanced disease, the PSMA PET scanning has been a real game changer in that, honestly, just up until a year or two ago, the standard workup for metastatic prostate cancer or concern for metastatic prostate cancer was a bone scan and a CT scan. But in a short period of time, the PSMA PET scanning has really taken off and become the state-of-the-art imaging. So that's a good question. To some degree, it depends on the starting PSA level. As a urologist and someone who does a lot of surgery for prostate cancer, the major dilemma that I face in practice is how to work up a rising PSA after prior radical prostatectomy. And I guess the good news, bad news. The good news is PET scanning is really taken off in that space to work up a biochemical recurrence. However, one of the greatest needs is in the setting of a PSA level at 0.5 or less, still the PSMA PET scans are about not as sensitive, and about a third of the patients will be positive when they have a PSA of 0.5 or less. Obviously, as the PSA gets higher, the positivity rate goes up. But as a clinician, one of my biggest frustrations or greatest needs is that in those men who have the lower levels of PSA, the patients are really nervous about it. They're stressed out that they have a rising PSA, and yet we can't really rely on the PSMA PET in those patients who have that lower level PSA recurrence. There's, all of a sudden, now that we have several PSMA PET scans available, to my knowledge, we have, I think, in the United States, 3 commercially available ones, but there's a lot of other companies who are now interested in this space. For example, we're working with a company to initiate a clinical trial using a copper-based, where it's a copper molecule, and pushing the envelope to see if maybe that will improve the sensitivity. But what I would say is this, the PET era has begun and it's taking off and there's more interest in it. So I think over the next 10 or 20 years, we're at GU ASCO 20. I'm not sure I'll be around at the 40th, but certainly we'll probably see tremendous things at the 30th and the 40th. And by that time, who knows, maybe the sensitivity and specificity will be, in the stratospheric levels. Clarity is, and they're obviously putting a trial in place in the biochemical recurrence space and in the newly diagnosed space. As a clinician, I kind of think about PET scanning in 2 buckets of patients. Certainly in the newly diagnosed high-risk patients, and then in the biochemical recurrence space. Where I'm running into problems is that if I have a guy with newly diagnosed metastatic prostate cancer, PSA of 100, bone pain, or someone who is really high risk, I need imaging right away. I don't want to delay treatment for the imaging. And so one of the challenges we're facing in the United States is immediate availability of PET scanning, simply because it's a limited commodity at most institutions to get on the PET scanner, and therefore a big need would be figuring out a way to make it more immediately available, especially for that subgroup of patients who present with pretty bad disease and need to be worked up quickly.